Not too loud. All right. Sweet. We good? Okay. Awesome. I'm gonna hide these. Hide floating meeting controls. Fantastic. Okay. So remind me, when was the last time you heard like a didactic on this subject? For some of you, never.
I still gave one, like recently.
It's been a while.
Unknowns.
Unknowns.
Mostly unknowns. Okay.
I think it was during my first year. 'cause
Okay.
Last year was unknowns.
Got it. So I figured it was probably time for a refresher on sort of broad strokes overviews of kind of mesenchymal pathology. You know, we have a number of sessions. Well, I've got 3 now, because then I teach in Pritzker, so it's kind of limited. So we'll do a little bit of a didactic now. On Thursday, since Peter Sadow is here to teach, I thought I would intersperse a head and neck one. You know, who's head and neck, and always like come and say hi to you guys. And then the third one I'll do will be more mesenchymal, and then we can decide. You let me know whether you want me to do more of this or do unknowns. So just keep that all in mind. All right. So in terms of when we're looking at a bone lesion versus a soft tissue lesion, the differential diagnoses are going to be different, and there's a few different kind of things we need to keep in mind for each. Today, I'm mostly going to focus on soft tissue, but some of these concepts are overlapping. But reminder kind of what to keep in mind when you're looking at a biopsy, because that's going to be the most important determinant of the subsequent therapy for these patients, right? So always age is going to help color what potential differential diagnoses you're dealing with. In the soft tissue, you're kind of looking at, is it superficial in the extremities, like a skin, skin, dermis, etc. Or is it deep intramuscular, or is it retroperitoneal? Because then your differential diagnosis shifts even more. Or is it in or attached to a visceral organ like lung or liver, etc. In bone, you're going to be asking yourself, which bone? Is it a bone that's ossified? Sorry, it's really warm. Is it a bone that is ossified intramembranously, like the craniofacial bone? Because that differential is going to be different than bones that are ossified endochondrally, like your long bones. In a long bone, you're going to be asking yourself the location in the bone. Is it the metaphysis, the epiphysis, the diaphysis? And when we talk about bone, we'll talk more about those locations. Or is it in the cortex versus the marrow versus on the surface of the bone? So all of these things important. Always kind of clinical pathologic radiologic correlation is going to be important, but more so in bone than soft tissue, because this is huge. And there can be mimics of sarcoma, there can be mimics of benign that are malignant, etc. Mimics of malignant that are benign. So always radiographic features in conjunction with your histologic findings are going to be super important. If you guys have access to the WHO online or the books, this is a great resource for what your differential is going to be. And you can see they're separated into soft tissue and bone, and then kind of overlap small round cell sarcomas. So as I said, we'll focus mostly on soft tissue. And please stop me at any point if you have questions. And are these lights okay? Can you see the screen? Okay, great. So we'll talk about broad strokes overview to soft tissue tumors. Then we can get into some various kind of subsites, and we can kind of choose our own adventure from there. But first, our overview. Patient demographics, as we already mentioned. Age, sex may play a role. Potential tumor syndromes, if known. Any prior pathology or prior radiation therapy. we talked about already where in the body, is it in the soft tissue of the trunk or extremity? Is it superficial, superficial, or is it deep? Is it in the abdomen, retroperitoneum, or visible organ? And then the basic morphologic pattern group, which I think is gonna be really critical to gauging our differential diagnosis. In terms of all soft tissue tumors, we're vastly gonna be dealing more so with benign tumors than malignant tumors. And, mostly we're gonna be dealing with lipomas, right? So we pretty much mostly know how to diagnose a benign lipoma if it's not, otherwise atypical. But, that accounts for the majority of soft tissue tumors. The most frequent location of benign things is gonna be superficial and mostly small, right? As opposed to malignant, which is mostly going to be larger and deeper. Just, again, common broad strokes, not always uniform. In between, there is this intermediate malignant potential category where either tumors can be very, very locally aggressive and therefore hard to resect and locally recurrent, such as desmoid fibromatosis, right? Or there's the rarely metastasizing intermediate grade, in which most of these tumors have less than 2% risk of metastasis. By definition, if they have more risk of metastasis than that, they kind of fall into the malignancies. So this is where the WHO has kind of sorted these out. For the malignant soft tissue tumors, the most common sarcoma is just undifferentiated sarcoma. And we'll talk about that when we get into the fibroblastic tumors. Next up, we've got liposarc, smooth muscle, lyo, myxofibro, synovial, and PNST. We'll talk about all these, but really most common is going to be undifferentiated sarcoma. Most frequently, you're going to get these in the extremities, sometimes trunk or retroperitoneum, especially for dealing with liposarc, right? And then again, as I said, deep. And up to 10% of sarcomas are thought to already be metastatic at presentation, right? So most are not, but 10% are. Most soft tissue tumors are sporadic, some are syndrome associated. So for example, development of neurofibromas, right, or MPNSTs and NF1 is probably the most characteristic. But we also get into things like retinoblastoma, Lee-Fraumeni, who have RB and TP53 mutations that are at risk for not only retinoblastomas, right, but things like osteosarcomas. What I want to mention about radiation-induced sarcomas is they're about 5% of sarcomas. Mostly, these patients have received at least 50 gray and are about 10 years after exposure to diagnosis, right? So this could be radiation for anything: carcinoma, sarcoma, melanoma, lymphoma, whatever. Usually what they get after radiation is high-grade undifferentiated sarcoma in the soft tissue, or of course angiosarcoma in skin. We already know that from breast, right? The problem is these syndromic patients, right, that already have some kind of tumor, they get radiation, then they are at even increased risk, right, for development of more post-radiation sarcomas. So not only are they at baseline risk for tumor, but they're at exponentially increased post-radiation risk. So sometimes in these syndromic patients, the initial question is, do you even radiate them to begin with, right? Because they're then going to be placed at increased risk for more tumors. So just kind of something to think about when you're asking whether something is radiation induced. Yeah.
So when you say median 10 years from exposure to diagnosis, I'm guessing that when it starts growing, grows really fast, right? It's not like slow growing kind of thing.
Yeah, usually in general, sarcomas are more fast growing than benign, right? But it's not necessarily exponential. It's fast. Okay. Yes, it's not like it's going to grow to 10 centimeters in a week, right? But it's going to grow to 10 centimeters in months or so. Yeah. So so it's not going to necessarily. I don't know why the 10-year delay, but the clinical presentation of the tumor is going to be about 10 years after. When the tumor actually starts is probably going to be somewhere around that time. Yeah. So it's not like you're going to see it at 1 month and it's going to slowly grow and then be present 10 years later. It's going to show up 10 years later. Yeah. There is no specific histologic subtype is the other thing I wanted to get. It's just a clinical correlation of was there radiation at that site and how long are we? Sometimes, and I'm going to say this because this is common in the head and neck, these patients get radiated for squamous cell carcinomas, and then they pop up with a spindle cell lesion in their mouth, in their mucosal sites. And when we have done molecular comparison between the original squamous cell carcinoma, for example, and the now 10 years later spindle cell lesion in the tongue, almost uniformly, they have the same driver mutations. So you always have to think about, if the patient had an original carcinoma or an original melanoma, could this just be a spindle cell presentation of that underlying other tumor, and is a recurrence in spindle cell morphology rather than a radiation-induced sarcoma, right? And sometimes the only way you're able to prove that is by molecular. So just keep that in mind for any spindle cell lesion, especially in cutaneous or mucosal sites, right, where those kinds of lesions are much more common than sarcomas. So caveat for that. Other questions? All right. So for most soft tissue tumors, surgery is primary treatment modality. For very high grade sarcomas, oh, I guess there's no very high grade, there's just high grade, or anatomically challenging, right, that surgical resection is going to be problematic. Sometimes they give chemoradiotherapy neoadjuvantly. Most don't. Most just undergo primary resection with further treatment determined by our parameters. So some ways to think about soft tissue tumors include the lineage of differentiation, which is how the WHO and the Enzing-Gernweiss book are organized, which I think is very good. We don't necessarily think anymore about, all right, is this an angiosarc? Did it come from a blood vessel? It probably came from a soft tissue mesenchymal stem cell that redifferentiated into endothelial morphology or immunohistochemistry, right? But not so much what's the cell of origin, but what's the lineage of differentiation, okay? So no more talk about cell of origin really anymore. I really like the Hornick book, which I think now is in second edition for, I was gonna say beginners, but really anybody, because it starts with a pattern-based approach. So if you're looking at something and you don't already have a differential, this will say, hey, this is what it looks like, here's your differential, right? So that's a book I really recommend. But of course, none of these work in isolation, so we have to use both of them in practice. The lineage of differentiation versus the histologic patterns are kind of listed here, but we'll get into that later. All right, so we as pathologists, when faced with a soft tissue or for that matter, bone biopsy, what do we need to do? We need to figure out if it's truly neoplastic versus a reactive process, because sometimes these things can be challenging, especially, for example, in bone, like a fracture callus, looks cellular, looks kind of atypical, maybe even have the differential diagnosis of osteosarc, right? So sometimes neoplasm, for like scar, right, versus nodular fasciitis, for example. Once we realize or think it's neoplastic, right, is it benign or malignant? And then if it's malignant, what's the grade? So we'll go through this in a second, but grade in soft tissue tumors is by the French system. And there's 3 grades, low, medium, or low, intermediate, high, but really 2 and 3, intermediate and high, for clinical purposes are considered high, right? So really it's low and high. For a low grade malignancy, it will generally just resect these with clean margins and watch. So like a low grade fibromyxoid sarcoma of the extremities, right? Gets a marginal or a local wide resection and watched. If it's a high grade, as I said earlier, right, some of these undergo chemoradiotherapy neoadjuvantly, followed by resection, and some just undergo primary resection. What are they asking for at tumor boards, right? You guys have all done these tumor boards. You know these surgeons are relatively, not very aggressive, but they want information, right? So if it's chemoradiotherapy first, right, they want the extent of treatment effect. They want the basically not really the grade, because that should have been diagnosed in biopsy, but the stage, if there's any residual, and then of course margin status. If these haven't undergone chemoradiotherapy, they of course want confirmation of the grade, the stage, and the margins, and this will then dictate the need for adjuvant treatment. Sometimes it's hard to distinguish benign from low-grade malignancy, and this is not always looked upon fondly. So unlike salivary gland, right, where we have a salivary gland biopsy, and we say, oh, low-grade salivary neoplasm, cool, there's nothing high-grade, I'm just gonna resect it with margins, I don't care if it's benign or low-grade malignant. Well, Rex Hayden is like, don't call it low-grade if you think it's benign, because when you say low grade, I think that's a low grade sarcoma, and my margins are gonna be slightly larger and this and this and that, alright? So we try to avoid using low grade as a descriptive term in these cases unless we are certain that it's malignant. So bland or, paucicellular or whatever as descriptors are fine, but grade gets a little bit hairy. Just, we had this recently, I just wanted to mention why that shift in terminology. We mentioned margins. So when you're grossing these, margins should be taken as perpendicular sections to show the interface between tumor and the distant. If the tumor is close to the margin, right, submit representative near margins. If the tumor is far from the margin, fine, just one rep to show that it's negative. But you don't necessarily need to submit the entire margin on anything unless you are submitting the entire specimen or the entire tumor bed. So usually reps are fine in these cases. If there is a fascial plane at the margin, that should be reported both grossly and or microscopically, because even if it's a thin plane and it's narrower than what an adequate margin would otherwise be considered, a fascial plane is considered adequate, right? Because they are kind of on the other side anatomically of that boundary. So fascial, sometimes they ask in tumor board, as some of you have heard, oh, there was fascia. Oh, was there fascia? Cool, it's fine. All right, so just that's why, because that's a whole anatomically separate compartment and they're fine with that. Margin status, what it does is it predicts local recurrence. That's pretty much it. Grade is what's going to predict distant metastasis and patient survival. So grading, as I said, is a French system. So I keep this handy at my desk to remind myself what these indicators are and what the exact counts are, right? So tumor differentiation score is, does it closely resemble adult mesenchyme? Or two, it doesn't really closely resemble mesenchyme, but I know what histologic type it is. And three is completely undifferentiated or uncertain. Then mitotic count, then necrosis, of course, pre-treatment, right? So we don't apply this grade post-treatment because tumor can increase in pleomorphism. It can get these wild nuclei, so it no longer has a differentiation. It can get treatment-related necrosis, right, which is not intrinsic to the tumor. So we really don't grade post-treatment. We report treatment-related necrosis, right, as part of treatment effect, but not in this manner, all right? So this is for naive sarcomas. If the total score, is 2 to 3, you're at low. It's 4 or more, you're at intermediate or high, which of course we know 2 and 3 are considered high. This grade applies to most tumors, but there are some that just have a default grade. If you're diagnosing a D. diff liposarc or a round cell liposarc or rhabdo, for example, some of these on the left, they are just by default high grade, right? So you don't necessarily have to apply the French system, they just are. Similarly, there are some that are mostly by default low grade, like myxoid liposarc well diff or low grade fibromyxoid sarcoma, right? So I'm trying to say, is this a well diff or is this a D diff? Is this a myxoid or is this a round cell? And then my grade will be established based on other indicators. And as we get to each of those areas, we'll talk about them. But just kind of as a reminder, not all necessarily need to be grade. And this is all in the introduction to the WHO chapter. So if you need reiteration of more of these concepts, read that introduction. All right, stage. So AJCC 8th edition, of course, is what drives the CAP staging, which is now in the electronic checklist that we have in Beaker, right? So soft tissue sarcomas. Just as a reminder, the T stage varies by site. So you have all these different sites that we're dealing with: head and neck, trunk, visceral organs, retroperitoneum, organ, right? So the T stage in these is going to be slightly different. The end stage is pretty much the same, although these rarely metastasize to nodes. Sometimes this question comes up on the boards, which sarcoma is going to go to a node. These are the ones that most frequently do: epithelioid sarc, clear cell sarc, alveolar, rhabdo. I mean, I've even seen jaw osteosarcs go to lymph nodes, so it's not never, it's just percentage, right? More likely, you're going to get distant metastasis to something like lung, right? That's the most common site of metastasis of sarcomas, as I'm sure you've probably seen on the thoracic surface. Okay, so we'll talk about general concepts of diagnosis, morphology, terminology, immunostains, and then differentials. Questions before we go on? Okay, so I kind of want to show you my approach to an unknown spindle cell lesion, with taking into account various parameters in no particular order. I've listed them as 1, 2, 3, 4, 5, but they're just for organizational purposes, not important. So first we'll talk about nuclear morphology, because I think this is one that is very important and we maybe need to look at in depth. So when we talk about the nuclear morphology of a fibroblast or a myofibroblast, right, we say that these cells have kind of oval nuclei with so-called open or kind of palish or vesicular chromatin, often with small nucleoli. Sometimes they're more than one per cell, sometimes they're one per cell, but they're small and they're not big and they're not red. And the cytoplasm tends to be very pale eosinophilic or wispy, right? So they have this very, very characteristic appearance, these oval nuclei, small nucleoli, wispy cytoplasm. When we say, well, what's the difference between a fibroblast and a myofibroblast? Well, I can't really tell on H&E, but by immunohistochemistry, they have some kind of myofilament in their cytoplasm, like Desmond, SMA, calponin, whatever. Indifference, smooth muscle should have a brightly eosinophilic cytoplasm and sometimes even cytoplasmic vacuoles. So as we'll see in a minute, sometimes smooth muscle can be difficult to tell from nerve, and it's often because sometimes nerve has oval nuclei and sometimes muscle has these vacuoles that look like myelin sheaths, right? So sometimes it's hard, but some clues can be there. Often these nuclei are uniformly very elongated, right? Cigar is the characteristic buzzword. And the fascicles intersect often at 90 degrees, right? So some are coming in parallel to the plane of section and some are coming perpendicular. And that's a good clue to smooth muscle, along with that very, very pink eosinophilic cytoplasm. Nerve sheath, characteristically, we think of the nuclei as being wavy or buckled with these pointy ends, right? But sometimes, as in this schwannoma, the nuclei are oval and not pointed at all, right? So just keep in mind that caveat. But what we do see here that gives us a clue as to what it is, right, is this very pink kind of fine fibrillary matrix that's breaking the nuclei into these like palisaded zones, right? You can see ancient or degenerative change, right, in nerve sheath tumors, where the nuclei become enlarged and hyperchromatic, but the chromatin is kind of smudgy, right? You're not seeing prominent nucleoli, you're not seeing this smudgy chromatin. Of course, you can see these kind of, symplastic changes in, uterine leiomyomas, et cetera. But we're not talking about uterus, we're talking about soft tissue. When we talk about the soft tissue tumors, we'll see that the uterus plays a whole different ballgame than the soft tissue. But generally, when I see this kind of stuff in the soft tissue, I tend to think about nerve sheath because that's pretty common in there. Okay, so then if you're not sure, what stains differentiate between these three major types of spindle cells? So myofibroblasts are kind of buried within smooth muscle. So they'll express the smooth muscle actin, the muscle actin, the desmin, the calponin, whereas smooth muscle will also express caldesmon and smooth muscle myosin heavy chain. So just in case you are wondering, or your immunoprofile is not clear. Certainly nerve sheath expresses markers of neural crest differentiation, most commonly F100 SOX10, right? So just how to think about when to apply these immunostains. We'll talk about immunos more later. Okay. Second thing that we're going to look at aside from nuclei are going to be cytoplasm, right? So if the cytoplasm is abundant and the nuclei tend to be more round, right? We call that epithelioid. If the nuclei are eccentric and the cytoplasm is pink, we can call that plasmacytoid or rhabdoid, right? Why? Because plasma cells have eccentric nuclei with paranuclear Golgi Haas. And rhabdomyoblasts, primitive rhabdomyoblasts have eccentric nuclei with really dense eosinophilic cytoplasm. So if you're calling something rhabdoid, you're kind of implying that the cytoplasm is eosinophilic. If you're calling something plasmacytoid, you're just implying that the nucleus is off to the side. So that's just a subtle difference in that term. And then lastly, there's this wispy or tissue culture-y kind of flowy cytoplasm, right? That tends to be fibroblast, myofibroblast in this kind of stellate appearance. All right, in tumors, in mesenchymal neoplasms that have an epithelioid morphology, interestingly, these are more likely to express keratins or epithelial membrane antigens. So maybe there's some kind of mesenchymal epithelial transition going on in these cells, but things like epithelioid sarcoma, epithelioid vascular neoplasms, epithelioid MPNST, rhabdoid tumors, sclerosing epithelioid fibrosarc, these, the morphology, and the immunoprofile kind of correlate in terms of they have cytoplasmic intermediate filaments that are keratins. Doesn't necessarily mean they're epithelial, right? They're just showing epithelial differentiation. Rhabdoid morphology may imply other different differentiation. So it may actually be, something plasmacytic or plasmacytoid. It may certainly be skeletal muscle differentiation or truly rhabdoid. But also when you see that morphology, also think about tumors that have chromatin complex remodeling aberrations. And this is not true just for soft tissue of the extremities. This is true in visceral organs, this is true in the GYN tract, etc. So rhabdoid morphology, throw on your INI1 and your BRG1 to potentially catch one of these tumors that have the SMARCB1 or the SMARCB4 gene rearrangements. And when we get into the sub-classifications, we'll get more into that later, but just as a reminder. Okay. Stroma. So stroma can be really pale and fine and sort of bluish, right? Or myxoid, which may imply that these cells are secreting connective tissue mucin. So if you talk to Dr. Krause, he'll talk to you about the difference between epithelial mucin, which is intracellular, and in vacuoles, etc., and secreted into the lumen of ducts, right? Versus connective tissue mucin, which is secreted by the myofibroblasts into the stroma, tends to be more bluish, etc. So this may be myofibroblasts, myoepithelial, or even cartilage. If the stroma is really, really dense and pink and collagenous, right, you're kind of thinking about something fibroblastic, myofibroblastic. Or you can get heterologous stroma, right? So you can get deposition of osteoid, you can get deposition of hyaluronic acid, either in the tumors of these respective things, right, osteosarc or chondrosarc, but also you can get heterologous differentiation in like a liposarcoma, for example, that starts to, produce a heterologous stroma. So just keep all of that stuff in mind. All right, and then architecture. So kind of zooming out, we can get a haphazard arrangement of cells that kind of go in all different ways, and there's no ifs, ands, or buts. This is kind of this tissue culture appearance that we sometimes see in things like nodular fasciitis or scar, right? There are these whorls or really short, tight fascicles that we sometimes call storiform that are common in things like fibroblastic or myofibroblastic tumors or even perineurial differentiation, right? So sometimes the organization can lead you to a lineage of differentiation or a particular differential diagnosis. And then there's long sweeping fascicles, sometimes called herringbone, especially if they have this pattern. These can be anything from benign, like desmoid tumors with these long fascicles, to more highly cellular malignancies like fibrosarc, synovial sarc, MPNST, etc. So the cellularity and the morphologic pattern can help you. Vascularity, right? So we have thin-walled, dilated, or branching vessels in which the tumor cells, right, kind of come right up to the edge of the vessel. This used to be called hemangioparasitoma-like, but we don't really use that anymore. But this could signal what used to be HPC, right, solitary fibrous tumor, what is now cholangioparasitoma in the sinus. Synovial sarc and MPNST also are characteristically have these quote-unquote staghorn or descriptively thin-walled dilated branching vessels. This anastomosing or kind of capillary network or chicken wire It's common in myxoid liposarc amongst other things, but that's what that is an example of. You can have thick-walled muscular vessels in something like an angioleiomyoma, where we just had one of these on service, or curvilinear vessels, in this case showing you myxofibrosis. Other features to always take into consideration are things like necrosis, mitosis, border, right? Necrosis doesn't necessarily always mean malignancy. It could mean there was a prior biopsy. It could mean there was chemoradiotherapy. So if you see tumor necrosis, always look for the presence of things like histiocytes, hemosiderin, fibrosis that imply there was probably some prior pushing around, right? If you have necrosis and then viable cells right next door without any of those other stromal changes, that's probably true tumor necrosis, and that could be a bad sign. Mitoses can be morphologically normal or morphologically abnormal, right? Like tripolar. If mitoses are morphologically normal, that could still be a highly mitotic benign thing like nodular fasciitis. But if mitoses are morphologically abnormal, that's no longer really benign. Border can be useful, but not uniformly, right? Sarcomas can have pushing borders and benign things can have infiltrative borders. Not soft sign, not hard sign. Okay. So when we have all these things and we're trying to apply immunostains, right, kind of where do we start? We always think about broad strokes, right? Sarcoma, melanoma, carcinoma, lymphoma, right? And if you're not sure where you want to start, right? You want to maybe start with some keratins for something epithelial, but right, keratins can also stain various sarcomas, as we already mentioned. Neural crest is overlapping between Schwannian and melanocytic, right? So Schwann cells and melanocytes all have S100 and SOX10, but melanocytes additionally have these. We talked a little bit already about the myogenic markers and the vascular and the other. So this is just your overview of what we commonly use, but I'll get into these more in a bit. So how do we differentiate between the keratins, right? There's the low and the high molecular weights and then the combos. So a CAM 5.2 or a low molecular weight keratin will stain non-squamous epithelium, so glandular epithelium, etc. So if you're searching for a spindle cell squamous cell carcinoma or just a squamous cell carcinoma or a urothelial carcinoma in general, right? Don't do CAM, do a high molecular weight, like a CK5-6. Squamous urothelial and myoepithelial will have those. Mostly I like to use AE1, AE3 because it catches it all. And then you can sort of go from there. EMA is the least specific epithelial membrane antigen because it often picks up other non-epithelial things, right? Like perineurial cells or some soft tissue tumors express EMA, but in context, it can be helpful. We already saw S100 and SOX10 being positive in both melanomas and Schwann cells, and in fact granular cell tumors, and in fact normal myoepithelium. And then we get into a little bit of differentiation between fat, cartilage, acinar, between the S100 and the SOX10, but just remember that any and all of those things can stain with these markers. We already saw a little bit of how the myogenic breaks down, but I wanted to add a couple additional points. So I got this chart from the blue book, the Rechtman and Bishop book. Help me out here. I used to call it the magic book. You know what I'm
Daily
talking about?
Guides book.
Yeah.
Yeah, I have the book, but I can't remember the name.
It's called practical something. Practical
Practical
whatever.
handbook for surgery.
What?
Practical handbook for.
Yeah, practical handbook for surgical pathology. Yeah.
On the previous slide, there was a picture of.
Amazing. Oh gosh, you yeah, that's what I thank you. You're already reading my mind and I'm not even reading my own mind. Thank you. So okay, so smooth muscle and myoepithelium tend to have similar immunoprofiles, right? Myofibroblast is somewhat restricted, skeletal muscle very much more restricted, right? But what's different about skeletal muscle, of course, is myogenin or MyoD1, which are nuclear markers of skeletal muscle differentiation. We already talked a little bit about fibroblast and myofibroblasts because morphologically they're very similar, right? But myofibroblasts essentially have some of myeloid in them and fibroblasts don't. That's kind of it. How do we regard vascular markers, right? So CD31 is arguably more sensitive and specific than CD34, right? Both of which are membranous, and some of which stain other types of cells, right? So you always look at your counter stain, right, to tell you what you're looking at. Because if you see CD31, but it's in small little things with eccentric looking nuclei, you're looking at plasma cells, right? You're not looking at necessarily the spindle cell tumor, for example, right? D240 is mostly going to be lymphatic endothelium, but also specific to certain sarcomas. Nuclear markers, right, are going to be both Fly1 and ERK. We tend to think about Fly1 as a marker of Ewing sarcoma, but remember that it is also an endothelial marker. So these are often used in concert. And again, I'm happy to give you guys this presentation when I'm done. So always check the counter stain, right, to see what's staining. And then of course translocations, right? So more specific than immunohistochemistry often are the rearrangements. And so these just keep growing and growing and growing. Some rearrangements have particular immunostains that have been developed right for them, and some don't. The great thing, right, about this institution that does not happen in many others is that our RNA fusion workflow will pretty much catch many, if you know, of these fusions, even if they're not validated, right? So thank you to our amazing molecular pathologists who've allowed us to be very diagnostically and sort of adventurously useful in finding these translocations, which can sometimes lead to a diagnosis. All right, so still, you know, we already mentioned, what do you have absolutely no idea? Broad strokes, right? Always just take a step back and say, all right, is it carcinoma, melanoma, lymphoma, sarcoma? And then we go from there, right? So we talked about keratin, we talked about neural crest, we talked for sarcomas, right? There's no sarcoma immunostain. As you have noticed, I have not seen Vimentin, and you will not see Vimentin in any of my presentations because it has no role in the differential diagnosis in my world at all, ever. It's not a mesenchymal marker. All it will tell you for me is the tissue immunoreactive? So if you can't get anything to stain and you throw a Vimentin on it and it's positive, okay, cool, the tissue is immunoreactive. In other specific differential diagnoses in other organ systems, it may have a role in a specific differential diagnosis, but it does no use in telling you that it's a sarcoma or a carcinoma or not, because it can be positive in any. The one thing I will mention is, you know, mostly lymphomas are going to be morphologically different. So they can often be identified based on H&E. We triage them downstairs. However, there are some that are more epithelioid or slightly more spindled, like these large cell lymphomas, that actually are on the differential with an epithelioid mesenchymal neoplasm. So that's why sometimes the CD30s, et cetera, or the ALKs come into play. Or for the histiocytic sarcomas, for example, that's where we might have an overlap with heme. Okay. I wanted to make a point on, after all is said and done, how do we set ourselves up for success, right? Starting in the growth room. And I know that you guys don't normally growth biopsies anymore, but I think to think about how and why we do things and how you will need to do things as you go out into practice is molecular is now, right? It's not the future, it's now. And so we always want to preserve the quality and the quantity of tissue for whether it be even IHC, FISH, sequencing, whatever. So at the time of growthing, if it's a biopsy, we like to split the cores up into different or multiple blocks rather than just siphon them all into one. Or why?
So you can use different blocks for cutting immunostains versus cutting molecular. So you don't burn through all the tissue.
Yeah, you don't want to burn through all the tissue, right? Because if you're going to order 30 IHCs on your 10 cores, then you're not going to be left with anything else, right? So if you split your 10 cores into 10 blocks, you can order your 30 immunos on block A, and still have your molecular left on block B or whatever, right? So it stretches the tissue. So always split the cores and process them either as undecalcified or if it's a biopsy as EDTA decalcified only. Don't put HCl on a core because we want to preserve as much tissue as possible for molecular. If you want the data, we have data on DNA quality and quantity, et cetera, between HCl and EDTA. HCl just kills it, right? Because it's a harsh acid. If you are dealing with a big specimen that you guys are grossing, right? Then you want to ask yourself, right? Am I able to submit undecalcified tumor? Yes, great. If not, then you have to say, all right, how much of this do I want to submit as EDTA decalcified versus HCl decalcified? And often that's a conversation that you may want to have with the pathologist. I would say, please, unless you are in a circumstance where it's a completely, you know, it's like an amputation for gangrene or whatever, if there's any suspicion that it's any neoplastic process, just don't ever HCl decal the whole thing. Please. Because there will be no longer any tissue left for any molecular testing needed. Here, right, we have DNA and RNA sequencing that will identify point mutations, copy number changes, fusions. They can tell a tumor mutational burden and if something has an ultraviolet signature, right, microsatellite instability, et cetera. And then we don't do too much FISH here, but those of you who had to send out to ProPath, to Julia Bridge, we know that we can look for specific gene rearrangements, especially if you want to preserve tissue, because that only requires like 3 or 4 slides as opposed to RNA sequencing, which requires a lot more, right? So that's why we might choose those different techniques. Comments, questions? Okay, so we've got 15 minutes left. Do you have preferences between, in the next 15 minutes, which of these subtypes we talk about? Or do you want to do something else? Like, look at virtual slides. I don't know, you tell me what you want.
I vote for either vascular or fibroblastic.
Okay,
Yeah, fibroblastic.
fibroblastic, all right. Narrow down. All right, so let me, yeah, okay, fine. Let me scroll down to fibroblastic. So that's probably, thank you all for choosing the toughest and longest category. But we'll get through what we can. Let me just screen share. Where'd the Zoom go? All right, share. Okay. Yep, so sometimes that's how we all feel about fibroblastic and myofibroblastic tumors, but we can get there. All right. So we're gonna start with paucicellular spindle cell tumors, of which these 4 are different. And those of you who maybe have some knowledge already, maybe you can guess what these are, but we'll get through them. So one of the first things I think is important for us to talk about is nodular fasciitis, because it's one of these things that can look like a lot of things, and if you don't think about it, you're never going to make the diagnosis. But the good thing is it has a specific gene rearrangement that can help us, right? So the clinical picture of nodular fasciitis is generally of rapid growth, right? So patient comes to presentation because they're worried about a sarcoma, right? You asked earlier about rapid growth. So this is one that is non-malignant but grows rapidly, sometimes after trauma. But usually it doesn't grow too big, right? So it's rapid, but it stays small. Dr. Kraus will tell you about his favorite worst case of a metastasizing nodular fasciitis, but we won't get into that. You can ask him for his trauma. All right, so this is one that can be circumscribed or highly infiltrative and can be misdiagnosed as sarcoma because it's highly infiltrative and highly mitotically active because it's rapid growing, but it's self-limited and it can regress if it's not excised. This has the characteristic tissue culture look, right, of the myofibroblasts, as we'll see in the next slide. And if you ever think of nodular fasciitis and you're not sure, send it for USP6 FISH and that'll be hopefully diagnostic. So, these are the things you might see. You might see microcystic or myxoid spaces as in the top left. You may see keloid-like collagen with extravasated red cells, it makes you think about a keloid. On the bottom left, you may see more cellular plump fibroblasts, and on the bottom right, kind of spinny cellular. You may see SMA, because these have some fibroblastic, myofibroblastic differentiation, right? But USP6 gene rearrangement is diagnostic. USP6 gene rearrangement, just for the board's takers, right, is also present in what? Aneurysmal bone cyst, either solid or cystic. Some quote unquote cellular fibromas of tendon sheath. Also in myositis ossificans, which the core of a myositis ossificans looks like nodular fasciitis. The periphery is bone and it's in muscle, right? So it's probably some deep, maybe intramuscular bone forming variant of nodular fasciitis. Okay. Other fasciitis that sometimes come into play are listed here: intravascular, cranial, proliferative, ischemic. You can read about these more on your own, they're pretty rare, but one thing I will point out is that they often have these ganglion-like cells. So if you see something that looks fibroblastic, myofibroblastic, but has these kind of ganglion-like cells, think about one of these fasciitis. Other benign fibroblastic, myofibroblastic things that we want to think about are fibromatosis. So if you ever want to make a diagnosis of a fibromatosis, you have to think about the subtype, right? It's not just fibromatosis. It's either deep fibromatosis or desmoid tumor, right? It's superficial fibromatosis or like the Dupuytren's contractures, which look very, very histologically similar, but are different in location and are different in the amount that they have beta-catenin mutations. Pretty much uniformly desmoid tumors do, not so much the Palmer or the plantar ones. But we know that the deep or the desmoid can be related to Gardner syndrome or FAP. So in a young person who has a desmoid, or you may want to raise that. The other thing that you may see in these patients are fibromas, Gardner fibromas, but we'll talk about that in a minute. We don't really see torticollis resected. This is a physical therapy issue, but this is on here just as for completeness. The characteristic ones that are like clinical pathologic correlations are kind of the juvenile hyaline fibromatosis, mostly in consanguineous families. The infantile digital or inclusion body fibromatosis, which kind of tells you what it is. It's in infants, it's on the digits, and it's got these inclusion bodies. The board loves to test on this. And then this so-called lipofibromatosis, which is super, super rare, but is a combination of fat and fibrous. But desmoid is probably going to be the one that you're going to see the most of the fibromatoses. So we talked about the long sweeping fascicles, right? This is that, but not being hypercellular, being very pink, being quasi-cellular with these linear arrays of vessels, and then these classic, right, oval nuclei, small nucleoli, and when you do your beta-catenin immunostain, you should see it localized to the cytoplasm, but to the nucleus. This can be a challenging stain to interpret because sometimes the cytoplasmic staining overlaps the nucleus. So I would look very carefully to determine whether you think most of the cells have nuclear expression or most do not. Where you won't see it, right? Normal beta-catenin, where's normally beta-catenin located in all cells?
Cytoplasm.
Membrane. Yeah. So you throw beta-catenin on any tissue, glandular, skin, what you'll see it on the membrane, right? That's not positive. That's just normal. Any pathologic beta-catenin that's going to be diagnostic of any beta-catenin abnormality is nuclear. Okay. Fibromas. So I already mentioned Gardner fibroma, so let's go there straight away. Unlike the fibromatoses, it's more collagenous, right? So it's less cellular fibroblast, more collagen rich, but it's beta-catenin related. So you can see these in kids. You can see them entrapping pre-existing structures here like nerves. So if you see something that's super densely collagenous, just sometimes think about a Gardner fibroma. If you look at something that's really collagenous, that's on a tendon, think about a fibroma of tendon sheath. If you see something that's between, below the scapula, right? Think about elastofibroma, which is generally gonna be in elderly patients, and you can see these wavy elastic fibers in them. If you see something on the distal palms of a kid that looks like calcified or kind of grungy, think about calcifying aponeurotic fibroma. That has these epithelioid histiocytes surrounding this calcified chondroid stuff. These nuchal fibromas, we don't really see very much, but you can think about them, again, with kind of fat and collagen admixed, in the nuchal sites of diabetics. Questions? Okay, so this is probably moving into the sarcomas, the low-grade sarcomas. This is probably one of the more confusing nomenclatures, but we can do it. And I love this slide because it really tells you the difference between these. The low-grade fibromyxoid sarcoma, or the LGFMS, or what used to be called Evans tumor or hyalinizing spindle cell tumor with giant rosettes, now it's LGFMS, versus myxofibrosarc, which can essentially be any grade. So by definition, low-grade fibromyxoid sarcoma is low grade. By definition, myxofibrosarcoma can be of any grade, and you have to grade it. Low-grade fibromyxoid sarc can transform to its high-grade counterpart, which is sclerosing epithelioid fibrosarc, which is distinct. LGFMS tends to be in younger people, 20s, 30s, on the extremities trunk. Myxofibro is a disease of elderly. LGFMS is usually very circumscribed, treated with local excision. Myxofibrosarc is highly infiltrative. It spreads along fascial planes. Characteristically, the surgeons will know that this is the diagnosis just based on the radiology because of the myxoid appearance on radiology and how it infiltrates. LGFMS has discrete myxoid and collagenous zones, right? So myxo, fibro, right? Fibro, myxo. Myxofibrosarc tends to not have these discrete zones, right? It can be more subtle or myxoid. Nuclear atypia is important. So low-grade fibromyxoid sarcoma should not have significant nuclear atypia. These are generally monotonous and bland and kind of spindly. Myxofibrosarc has random atypia with enlargement, etc. They often also have the atypical cells that cluster around the curvilinear blood vessels. So that's a helpful clue. Treatment is potentially going to be different, especially if you call something a high-grade myxofibrosarc. These patients may undergo neoadjuvant therapy, but certainly all will get resected. Recurrence is very low, but these can metastasize late, like 10, 20 years after diagnosis. And high-grade myxofibrosarcs certainly have more risk of metastasizing. So this is the difference, right, between an LGFMS on the left, low-grade fibromyxoid sarcoma, and myxofibrosarcoma on the right, right? Myxofibro, think curvilinear blood vessels, more atypia, not discrete zones, right? What's great about this differential diagnosis, aside from if you haven't already sorted it out between, age, location, whatever, LGFMS can sometimes mimic other low-grade spindle cell neoplasms. It can mimic nerve sheath, it can mimic muscle, whatever, but it stains for MUC4, mucin 4, and EMA, epithelial membrane antigen. So MUC4 and EMA are going to be critical if you ever want to make a diagnosis of LGFMS. Sometimes, if you're lucky, you'll see these giant collagenous rosettes. That's where the name of this tumor originated from, but you don't always get lucky to see that. So if in a low-grade fibromyxoid sarcoma, you start seeing more cellularity, more plumpening up of the cells, or this linear arrangement of plump cells between collagen, almost looks like lobular breast cancer. This is now on the transformation to sclerosing epithelioid fibrosarc. Sometimes these arise from an LGFMS, and sometimes they arise de novo. They still have EMA and MUC4, but depending on whether they are hybrid or pure, the partners are different. So LGFMS and hybrid LGFMS SCF has these FUS Partners. Pure SEF has this EWSR prep, so this is all kind of a spectrum. But usually morphology and IHC can get you to the diagnosis with confirmation of fusion if you want. I put in here a chart of differential diagnosis of your kind of paucicellular myxoid or myxoid spindle stuff. You know, this is in the nerve sheath section, right? This is in the fatty section. There's not too much, right? There's not too much in the fibroblast, myofibroblast that's gonna help you, but you can certainly exclude nerve sheath things, right? If that's on your differential, which it often is with myxoid processes. Okay. 2 minutes left. Want me to do? Yeah, let's do the cellular sarcomas. So again, these are all 4 different things. So we'll start with synovial. That has nothing to do with synovium. It was called that because years ago, it often occurred around joints, like around the knee. It's not related to synovium, it just happened to be located in your joint, so it's called synovial sarc, but whatever. Mostly this is a tumor of young adults as well as low-grade fibromyxoid sarc, right? Synovial sarc is generally a young patient, 20s, 30s, not pediatric necessarily, but like young adult. It can be either monophasic or biphasic having also these gland-like components. Growth pattern can be fasciculated, storiform, thin-walled blood vessels. What you always want to think about with synovial sarc, if it's on your differential, always you should have some kind of EMA or keratin immunopositivity, even in the pure spindle ones, right? So this is not just, oh, there's keratin in the gland component. There is, but there should also be keratin or EMA in the stromal component, and that's a pretty good screen. TLE1, which used to thought to be a specific nuclear marker for synovial sarc, is not so much. TLE1 is positive in a lot of other mesenchymal neoplasms that are not synovial sarc. It's positive in a lot of spindle cells, carcinomas. So we don't really, if it's negative, cool, it's probably not synovial sarc. But if it's positive, meh. So you need the keratins and the EMAs. Arguably more importantly, you need the genetics. So the biphasic has the SYT SSX1, the monophasic has the SSX2, but we can send a Julia Bridge and ProPath, or we can do the RNA fusion panel for these. Generally, with sarcomas that have diagnostic fusions, we generally will do the testing for proof, because especially if it's a young patient, we want to get the answer right, and it may change management. So we've had examples of like a plump synovial sarcoma and a slightly spindled Ewing's kind of mimicking each other, right? And this is going to be different treatment for something like a Ewing's versus synovial sarc. So in these hypercellular malignant blue spindly things, the genetics is going to be really helpful. Okay. FFT is another cellular spindly thing that can be highly variable, from super collagenous to supercellular. It almost mimics a synovial sarc or a glomangioparasitoma. What's common amongst all of them, right, is the fact that they are of fibroblast, myofibroblast lineage, or differentiation, I should say, and have CD34 and STAT6. Once you get, you may be asked the question, is it a malignant SFT? In many people regard all SFTs as potentially malignant and use these histologic predictor systems to infer or to imply a potential behavior, right? So things that are deeper, things that are larger, things that are hypercellular, have increased mitosis or necrosis, every single thing you get puts you higher on the risk spectrum for metastasis, right? But none are zero. Well, some end up being zero, but it's a range. It's not there's a cutoff between benign and malignant. You characteristic clinical pathologic correlation, right, it needs to create IGF-2, so the patients may be hypoglycemic. And the prototypical site is a pedunculated thing off the pleura. So you'll see these in the thoracic surface as well. You'll see these in the soft tissue, and you'll see these in the sinuses of the head and neck. All right, I got a couple more left, sorry guys. IMT, inflammatory myofibroblastic tumor, is another one of these things that is really, really rare, and sometimes I forget about it, right? But it's kind of on the maybe nodular fasciitis or fibromatosis differential, right? Where you have this fibroblast, myofibroblast picture, but lots of inflammatory cells. If you're lucky, you'll have an ALK be positive by IHC or by molecular. But sometimes this is really a diagnosis of exclusion. And I'll have you guys read more about this in the books, but just remember that it exists, and ALK is not always positive. Especially if you are an adult patient, you may have a fusion negative IMT, so you will never really be able to prove it with genetics. It's just gonna be a morphologic correlation. More hypercellular things with elongated or herringbone fascicles, right, is fibrosarc. There's pretty much two types of fibrosarcoma that I will actually diagnose. One is infantile, which is defined by the specific ETV6 NTRK3 translocation, right? And the other is a transformed DFSP in an adult. That's pretty much it. Historically, you may see somebody call an undifferentiated sarcoma a fibrosarcoma. That terminology is no longer really accepted. There's pretty much two fibrosarcs, the one in the infants and the one that comes from a DFSP, but they look very similar. They're very hypercellular, very elongated fascicles, mitotically active. So, caveat with this I want to make is when you see a dermatofibrosarcoma protuberans, which is in one of these slides, always look for these areas that are hypercellular and fasciculated and mitotically active, because you don't want to miss a fibrosarcomatous transformation of a DFSP, because this patient is now at risk for metastasis rather than just local recurrence, okay? So we've seen fibrosarcs be missed because, you know, one's, oh, DFSP, cool. Always ask yourself, what can be worse? Can there be something worse? And in some cases, there can be. Okay. ETV6 NTRK, you know, NTRK is now in a lot of things. It's in a lot of sarcomas, it's in secretory carcinomas, etc. So this list is growing. This is not complete. NTRK is now rearranged in a lot of things. And then lastly, high-grade spindle cell undiff sarcoma. So you may hear of this or see prior reports as undifferentiated pleomorphic sarcoma, or a long time ago, malignant fibrous histiocytoma. The name pleomorphic was removed from undifferentiated sarcoma because not all of them are pleomorphic. Some of them are just spindled and mitotically active and necrotic. Some of them are actually pleomorphic. So now it's undifferentiated sarcoma, spindled, pleomorphic, ground cell, whatever. But essentially, if you have something like this, you want to prove that it's not something else. It's not D. diff lipo, it's not pleomorphic rhabdo, whatever. At that point, you can say, yes, it's an undifferentiated sarcoma, which is mostly what we're going to be dealing with, as I said earlier, in adult soft tissue sarcomas. Here's the list of the highly cellular differentials for your review. All right, it's 9:06, so I should probably stop. Is there any particular disease that you heard me mention that I didn't talk about that you want to see? Okay, all right, so cool, I guess we'll stop there. Think about for the next sessions whether you want me to continue on this presentation, whether you want me to give you unknowns and just give you the PDF of the presentation to look through on your own. So just let me know. Thanks.
Thank you.